Hello, everyone. Welcome to our live NCLEX RN review session. If you are joining us for the first time, we are currently on day 26 of our complimentary 90-day NCLEX review series. And throughout, we're going to talk about the range of nursing topics while thoroughly dissecting 2000 NCLEX questions. So spread the word to your NCLEX preparing friends. Our classes are completely free, and don't forget to like, subscribe, and also turn on notifications to stay updated with our latest content. And so for more details, check the description box below. Your feedback is invaluable to us, so feel free to share your thoughts and also your questions in the comment section, and we'll be happy to provide further clarification. And also, we are offering the NCLEX review course today at Stancoast NCLEX Coaching. So you can discover the personalized guidance tailored to your needs at www.stancoastnclexcoaching.com, and where you can engage in interactive lectures and also tackle over 3,000 NCLEX-style questions to enhance your learning. And you can also explore our 10-hour animated video course and enjoy flexible study sessions with about 100 hours of preparation time in order for you to boost your confidence with our on-demand video library and mock exams. So you can do this for 6 months, full access, including 200 plus NGN questions to make you fully prepared for the examination. And you can study at your own pace on our user-friendly platform designed for your success. So we're here committed to supporting you every step of the way. Now, guys, we are going to focus on the nursing management for the bronchiectasis, lung abscess, and also empyema in this lecture. So let's get started. Now, here we're going to have to tackle first the bronchiectasis, which is a chronic, it's a pulmonary disorder that is characterized by the persistent inflammation and also dilation of the bronchi. So as you see here, with this airway being filled with that mucus and also inflamed airway, this is really going to make the breathing so difficult for this patient, and it can lead to so many complications, including respiratory failure. And we're going to have to talk about the pathophysiology here, wherein the disease itself can arise from so many underlying factors. Maybe it could be caused from immunodeficiencies such as AIDS, HIV, could be the cystic fibrosis, and also any aspiration events and alpha-1 antitrypsin deficiencies, which is a common characteristic of the emphysema, and so with other respiratory infections. Now, talking about the bronchiectasis, with the inflammatory process, this can really cause some structural damage into the bronchial walls. So right here in the airways, and it can also lead to the accumulation of the thick, it's going to be mucoid, and this can cause obstruction of the airflow, and this will make the individual to be prone to developing some more infections, as we know that with the presence of the fluids and also mucus in the airways, this can be a good medium for the bacteria to grow. Now we just have Florice Barad. Welcome to the class today. And so for the rest of the class that have been quiet, welcome. Now, the condition itself can also affect a single or could be a segment of the lung, or it can be more widespread, affecting probably the entire lobes, and also it will probably diffuse over to the entire lung over time. Now, the bronchiectasis actually is going to develop as a consequence of respiratory infections. Let's say the pneumonia, could be tuberculosis, which can really damage the bronchial walls, and this can also lead to accumulation of the thick mucus. So guys, don't get confused here. The concept is pretty much easy. With a bronchiectasis, think about the inflammation and the excessive mucus secretion. So these are the hallmark of bronchiectasis. And of course, with the infections, that can really overwhelm this patient. Now, with the complications, let's talk about the complications here, guys. Well, it can also lead to the structural damage, right? As I have said, pretty much affecting the bronchial walls, and it can lead to airway obstruction. And if this is going to be obstructed, well, what do you expect? There will be significant hypoxemia, hypoxia. The blood supply to the major organs in the body and also the periphery will be compromised. So again, this is a major issue. Focus your nursing in the airway patency. Okay, this is your focus, especially if you're going to be asked in the NCLEX about what priority nursing action you should provide to this patient. Then target the airway. Okay, now atelectasis, because of the poor exchange, because of the obstruction in the airway, then the alveoli will eventually collapse. And we know that before it happens, then there will be diminished breath sounds, and then it can lead into absent breath sounds. And it could probably affect a much more of maybe a single lobe or two lobes or maybe three lobes. And eventually this can also complicate into the deviation of the trachea. And that would be so life-threatening that you need to really address. Now, we're also going to talk about the fibrosis, which is the result of the inflammation that is chronic. This can lead to a non-functional portion of the lungs. It will not be able to deal with the air exchange. It's just a scar tissue that has been going on for quite some time. And here we're going to have to identify those clinical manifestations that you should know about. You should identify readily what those key or hallmark in this patient. So let's talk about here about the increasing sputum. Okay, so that is top in our list. Okay, and our patient will have persistence in their coughing. It's going to be productive. It will be copious amounts of sputum, and this is purulent. Okay, so think about Shrek in this situation. Just the color, that yellow greenish color. Think about Shrek and Fiona in this disorder. And in some cases, this is really difficult to clear out, especially with coughing. It's very difficult to expectorate because of the thickness, the tenacity of the mucus itself. And in some cases, this can also lead to hemoptysis. That blood streak in the sputum. The person will be coughing up blood. There will be dyspnea, and there will be recurrent fevers and frequent pulmonary infections as well because of the presence of the mucus, right? There will be crackles, could be rhonchi if it's the mucus is trapped in the larger airway, so you will expect the rhonchi as well. And also the clubbing of the fingers. Basically, it's going to tell us that the patient has not been getting enough oxygen for quite some time. It's been probably months, several years that they have to deal with this kind of condition. And that simply means that the patient has chronic hypoxia. Okay. Don't forget about the clubbing of the fingers. All right. Now, as we are going to move along here, we're going to talk about the diagnostic tests that will be performed in order to properly diagnose a patient. And one of this is the high resolution CAT scan, which is really important in giving us a better picture of the bronchial dilation, and also will give us better image on the structural deformities inside the lungs. Okay, so don't forget about this, the CAT scan. Another is the chest X-ray, and this is going to give us an idea of where those areas that may have the atelectasis or the lung collapse. There's no more air exchange into those areas because of the obstruction. And there will be dilation of the bronchioles. Okay, The airways will be dilated. Okay, so let's take a look into this picture. I don't want to waste this image. So there is widening of the airway. There will be fibrosis or scarring of the airway wall on top of the increasing sputum or mucus plug inside the airway. All right, so don't forget these hallmark, okay? Widened airway. There's also scarring, fibrosis of the airway wall, and again, excessive mucus secretions, which is very difficult to cough up, okay? All right, so I hope that clarifies things. And another is the pulmonary or sputum exam is very important. And this is going to identify if the patient has a specific microorganism responsible for the recurrent infections. Okay, so that is the role why we're going to have to collect the sputum sample. And this is to check for the microorganism and also to identify the sensitivity of that microorganism against the antibiotic so we can treat the infection. And we also have the pulmonary function test, or the PFTs, and this is going to check for the airflow obstruction, and this will also assess the impairment of the lung function. And of course, this will guide the care and also the treatment that will be ordered by the medical provider. All right, so simply those are the assessment findings and the diagnostic tests. So I hope that you were able to catch on those. Now let's talk about the treatment. Oh, so we got all those ahead of time, right? So the treatment basically is to manage the bronchiectasis, and this is to prevent the progression. Okay, so let's take a look. This is to prevent progression. Because you know, guys, the complication of the bronchiectasis is what? The fibrosis, right? And when it gets to that point, the lung tissue can no longer function. And so we want to halt the progression. Make sure that we are treating this condition as early as possible and make sure we are managing the manifestations when it arises. Okay. We're also going to have to alleviate the manifestations. We're going to have to reduce the exacerbations, and also we have to improve the patient's overall quality of life. And so here, part of the care is the infection control. This is big deal, okay? Because again, this will really cause the exacerbation, right? And so part of the care is to administer the antibiotics according to the culture and sensitivity. And we are going to incorporate cessation of smoking, which is very crucial in making sure that the patient's manifestation will be lessened. It will also decrease the exacerbation of the symptoms. And the immunization is also very crucial because this can protect the patient from the respiratory pathogens, let's say the influenza or the pneumococcus. So don't forget about the influenza annual influenza shot and the pneumococcal immunization. Pneumococcal. So these are the two immunizations that we're talking about. Now, part of the treatment is also to teach the patient, make sure that we are educating them to how to properly clear their secretions. Of course, we have mentioned this in the past in the other topics, like I have mentioned. I believe this was on the acute bronchitis. And so we're going to include the postural drainage. We're going to have to educate the patient about the benefits about this procedure with the use of the positive expiratory pressure devices like the flutter valves, the acapella. Again, this is the PEP. And remember about that object or that device that the patient will have to use that green thing that I've showed you in the yesterday's session, wherein they're going to have to create a tight seal around that mouthpiece. And they're going to take a deep breath. And when that happens, it can cause vibration into the patient's airways. And this will lead to the expectoration. It can cause movement of the mucus from the airways to be easily cuffed up. Okay. So don't forget about the flutter valves and also the acapella. And we're also going to collaborate with the respiratory therapist in the use of the vibratory chest therapy. It's that kind of like a jacket kind of device that has the jacket has those vibration. It has that effect to cause vibration into the chest to allow expectoration of the mucus. Okay, and again, this is supposed to be done before meals. Okay. And same thing with the chest percussion or the chest physiotherapy. That's also going to be done before the mealtime. Now, along with that, there's also going to be the use of the bronchodilators. Usually this is going to be used in the treatment, such as the vibration of the chest and also the chest percussion in order to facilitate the removal of the mucus. Okay, so don't forget about the beta adrenergic 2 agonist. This is going to dilate the airways. It will facilitate the secretion clearance. It will also improve the airflow. And so the patient's shortness of breathing will be much lesser at this time. And part of the care is to implement pulmonary rehabilitation. So this is going to include those exercise programs that will enhance the lung function. And also this will promote much more of their physical endurance, their overall well-being. And the patient will be taught into much more structured exercises that will be aimed at improving their respiratory muscle strength and also their endurance. And we're also going to have to manage their acute exacerbation. So around this time, we need to have that early recognition, and also we want to make sure that we are going to implement the administration of the antibiotics. Okay, let me just write down ABX, the administration of the corticosteroids in order to reduce the inflammation. Okay, so let me have that. Antibiotics, corticosteroids, and also oxygen. So this is going to be needed in the exacerbation phase of the bronchiectasis. Now, when this happens, especially if the person has the severe form of exacerbation, and this will really require hospital admission in order for us to intensely in order for us to intervene in much more intense type of therapy to this patient. Okay, especially if they're really going to have air compromise or airway compromise, then definitely the patient will need to be monitored much more frequently. Yeah, that's not going to be a good idea to have them stay at home and treat themselves with the medications. No, that would not be safe. Now let's talk about segmental resection. So what is this? Well, this is going to be indicated if in case all the treatment modalities have failed for this patient. And so we really have to prepare them for this kind of procedure, so to lessen their anxiety, and also they will be able to understand better the education that we'll be giving them that will be important, especially post-surgery. Okay, because there's a whole lot of things that will be involved after they get the invasive procedure. Now we will talk about the complications here of the bronchiectasis, and pretty much here all the complications are just kind of recycled, and so it's just to kind of recall them simply. And so top of the complication here is the COPD, the emphysema, and this is going to coexist with a bronchiectasis. So don't forget the COPD as the topmost complication because of the chronic inflammation of the airway, There's also chronic production of the mucus. So not just emphysema, but also the bronchitis. So because these are the two forms of bronchitis. Let me erase that. I forgot to include the bronchitis in this slide. Okay. And this is really going to make the treatment very challenging if the patient will lead to this complication, because all the more the patient's care, the treatment will be much more complicated. It could last for weeks in order to clear out the infection. Now, we're also going to expect that the patient might go into respiratory failure. This is not a fun episode, guys. Whenever our patient starts to fail, everyone gets excited. You're the primary nurse in this patient in the med-surg setting. You're going to end up calling the rapid response, or if not, you're going to call the code blue. Also, around that time, everything gets so hectic. And yeah, the patient, once they get sent to the ICU, everything will be so rapid, the treatment will be so intense, and eventually they can come back to the med-surg unit after they get better. But your approach in the nursing care for this patient will be much more of like structured. I'm talking about like you have to keep a more vigilant eye into this patient, because they can just flip back again and go into that respiratory failure again if you're not being careful to catch the subtle manifestation. So yeah, they can come back in and out of the ICU pretty much. Now we're also going to talk about the pulmonary hypertension, and this is another life-threatening complication. It's because of the chronic lung damage. It will cause the scarring and also increase the blood pressure in the blood vessels inside the lungs, especially the arteries. And with that, it can complicate into cor pulmonale, which is basically the right-sided heart failure, RSHF. There will be dilation of the right chambers of the heart, the atrium and the right ventricle. And here you're gonna be seeing a whole lot more of complications, revealing all those signs involving the venous circulation, such as the vena cava. It can push down circulation to the lower extremities. You will see the patient developing edema, also causing pulmonary, or the what do you call this, portal hypertension rather. It can cause issues into the liver, probably would result to ascites, and you will see that the patient will have the distension of the jugular vein. With that positive JVD, they're going to end up short of breath as well, and also widespread edema for this patient. So it's not fun to watch having these complications. Yeah, I just don't like seeing our patient having difficulty of breathing. It's really going to exhaust you at some point. Another is that your patient will also end up with a hemoptysis because of the damage in the airways, and it can lead to much more fragile blood vessels that can easily bleed, causing this blood vessels to rupture. And there is also that major pulmonary hemorrhage, and the same rationale for that. It's because of the damage of the airways and also the capillaries, and the excessive mucus production is one of those. The person will end up with the obstruction of the airflow. This can also lead to some more infections and much more of a complication, worsening of their condition. So let's talk about the nursing assessment for the bronchiectasis. So what are we going to expect? Well, we are going to focus on the patient's work of their breathing, their effort. That is one. We're also going to have to assess the respiratory rate, the saturation. What else? The symmetry of their chest when they're breathing in. We're going to have to look for the use of the accessory muscles in order for them to breathe or even to catch a breath. So those are the things that you're going to expect in this patient with the bronchiectasis. And on top of that, we're going to have to assess the amount of the sputum that they're producing. Okay. And again, with a bronchiectasis, it is expected that their mucus production is much more, right? The volume is increased, and this can really plug up the airways. And definitely don't forget to auscultate the patient's lungs from time to time, regularly at even intervals. Make sure that you're looking for those adventitious sounds that could potentially cause lung collapse, right? Let's say crackles, rhonchi, diminished breath sounds, or absence of the breath sounds. So the progression of these adventitious sounds is something that you need to keep an eye out, rather. And we're also going to have to monitor for the patient's respiratory distress, assess and monitor for the distress. If there is any change in their quality of respiration, in their blood gases, their saturation, then this will call for a notification to the medical provider. Always think about notifying the medical provider if there are drastic changes. Okay, don't forget to notify them. Now we're also going to have to keep an airway. Make sure that it's patent. And so top of our intervention here is to make sure we are incorporating essential positioning of our patient to allow drainage. This is going to cause the passage of the mucus through different positioning by gravity. And this can also decrease the infection. And however, though, you got to be careful with the postural drainage. So if in a case wherein there is a problem with an increasing intracranial pressure, let's say, for example, this patient that has the bronchiectasis also has some issues in their brain structure. Maybe they have some form of ICP problem. And so you have to be very careful not to do the postural drainage because this can exacerbate an increase in the ICP. So I'm just throwing it out there for you to make sure you are safeguarding your patient. So again, there will be some caveats, there will be some exceptions, okay? So this is not going to be, or this is going to be contraindicated in increased ICP, right? Don't do the postural drainage because, like I've said, it will require the patient to be placed in different positions, side lying, probably allowing the patient to have in a Trendelenburg's position. Yeah, not good for this patient. Now, talking about the vibratory vest therapy, which I've already mentioned quite a few times now, this is going to involve the PEP, the positive expiratory pressure, with the use of the flutter valves, the a cappella device that can cause oscillations in the patient's airway to promote removal of the thick secretions. And there's also the chest percussion or the chest physiotherapy in order to mobilize the secretions after they have taken the bronchodilator. So this is going to be done with the use of the bronchodilator to promote the passage of the thick secretions, right? So you really have to coordinate dilator. Okay, I think I spelled it correctly. You have to coordinate with the respiratory therapist when to exactly do this. Make sure that this is done before meals, and also coordinate with them regarding the administration of the medication. Okay, now we are going to note, here's another caveat with a chest percussion. This is also contraindicated in those patients with osteoporosis, or for those people that have known rib fractures. Okay, so please take note of the contraindications. Or for those people that may have vertebral fractures. So this is really gonna make the treatment a little bit more challenging. Okay, vertebral fracture, rib fractures, and also osteoporosis. All right, so they might benefit in the use of the PEP instead, okay, but not the chest physiotherapy. So please take note of the following contraindications here, guys. So for the postural drainage, that is contraindicated in those people with increased ICP, whereas the chest percussion is contraindicated for those people with osteoporosis, rib fractures, and vertebral fractures. Now, that could be asked in the NCLEX, maybe about the risk reduction potential. So that could be asked in your NCLEX. So just make sure you remember this. Now, we're also going to incorporate instruction of effective coughing in order to clear their secretions, and we'll have to encourage them in doing physical activity once they are more stable, and make sure that they are taking in more oral fluids to thin their secretions, and also with the use of the vaporizer in order to humidify the air, and this can also loosen or thin their airway secretion. So very important, guys. Now let's recap. In order to maintain airway clearance, we're going to have to assist them for postural drainage, that is one, the use of the vibratory vest therapy, the use of the PEP, chest percussion, and also effective coughing techniques. We're going to have to increase their physical activity and the intake of fluids, and also with the use of the vaporizer. But don't forget also with the contraindications and the other caveats. You have to really take into the other factors into consideration. Now, moving forward with the patient education, this is really going to help us in further managing the patient's bronchiectasis. Of course, we are going to have to also educate their family members, maybe their caregivers at home, so they can implement the treatment much more carefully at home. And one of the key elements in the education is the smoking cessation. This is very crucial, guys, because most of the patients that have respiratory problems, well, unfortunately, they are also cigarette smokers. So it's really going to make the education very difficult and challenging. And so with this, we need to talk with the patient about the importance really of quitting, right? Make sure that they have the idea, awareness that what they're doing for quite some time is not really going to help them, all right? And this is a known respiratory irritant that should be avoided at all costs. So as soon as they're going to prevent themselves or avoid themselves from taking any more cigarette smoke, maybe secondhand, this will really cause a whole lot of improvement. And also we're going to have to teach them about the pulmonary drainage, and this is something that they can do. And again, with the use of the PEP, and I'm not going to repeat that. There's also the postural drainage that they can do at home, the physical activity, and make sure that they are practicing oral hygiene. This is very important, okay? Why? Because the oral hygiene can really do a whole lot of improvement, okay? And the reason for that is because when they are coughing a whole lot of the thick secretions, some of these can probably get lodged into their mucus in their mouth, and can also allow growth of the bacteria in the oral space. And this can now also complicate if the microorganisms can go down into the lower respiratory tract. So make sure that you are teaching good oral hygiene every now and then, even after they cough those thick secretions, okay? Now, part of the care is to teach them about the importance of getting the yearly flu immunization and also the pneumococcal immunization in order to protect them from the respiratory infections caused by the Haemophilus influenza and also the pneumococcus organism. Now, around this time, we're going to talk about a next problem, which is the lung abscess. Now, you're already seeing this lung with a chunk of pus or abscess collecting into one of the lobes. And so the lung abscess is basically an infection in the lung that can lead to pocket of pus being formed in one of the lobes. And this is happening because of the tissue that has been destroyed, and it could be as a result to a fibrous wall that has formed around the infected area. And so pocketing is that hallmark, okay? Pus-filled cavity. So that is how a lung abscess is developing, okay? So again, it starts with the infection in the lung, parenchyma itself. It's not in the pleural space, but in the lung tissue. And with that pocket of pus, this is really going to cause a lot of problems. It will grow bigger. Now, what do you think are the common causes of the lung abscess? Well, there are so many of them. And one of those is the aspiration of the vomitus of probably food contents, or could be an infected material from the upper respiratory tract into the lungs. And this could be also caused by the pulmonary embolism, or it could be trauma. In some cases, this is caused by TB, also the necrotizing type of pneumonia, and it can really cause localized damage and more infection into those areas. And here we have the, especially with the cavitation, right, in pulmonary tuberculosis, this will be creation of the pus abscess inside the lungs. Now, another contributory factor here is the bronchial obstruction. There's also that presence of infection caused by the Klebsiella pneumoniae and the Staphylococcus aureus. And these are causative microorganisms that a person can get in the healthcare setting. So these are known nosocomial infections. Nosocomial infections. INFXN. So that is my shorthand for that. Okay. Now, we're going to talk about the clinical manifestations of the lung abscess. So pretty much it is quite similar with the bronchiectasis. So what you're going to do here is to narrow down the manifestations, and these are the coughing that is productive. They're also going to experience some fever. They're going to feel unwell. They just have that body malaise. And again, this is caused by the inflammation and also the response of the body from that infection. There are also going to be some headache rather, and anemia. There also be weight loss, weakness, shortness of breath. It really is going to tell us that this infection is really affecting the whole body. And in some cases, it might lead to chest pain, which is pleuritic in nature. Okay. This is going to happen when the infection will spread into the pleura of the lungs. And the classic manifestation here is that foul smelling sputum. Even just a little bit of distance from the patient, you can smell that putrid odor. Okay, so this is characterized by dark streak. Maybe it is going to have some blood in it. It will happen so much more with this patient. Again, the sputum is purulent. It could be often blood streaked and very foul smelling. Now, what you're gonna probably elicit when you are percussing the patient's chest walls, when you are percussing, then there is that dullness. Well, it simply means that the lung fields are consolidated. There's fluids filling those alveoli, the airways. So that's why you're gonna have that dullness, no resonance at this time. Now, there's also going to be absence or diminished breath sounds, and due to the poor exchange of the gases between the airways, And there will be intermittent pleural friction rubs that you can assess. You can auscultate this mostly in the axillary area using that stethoscope. Of course, this is going to be an indication that the patient has some irritation in the lining of the lungs, the pleura. Okay, so don't forget about the intermittent pleural friction rub. So that is the grating sound, friction against those two layers. Now we're going to talk about the different diagnostic tests here, which will help in the accurate diagnosis. And also we have one of the topmost diagnostic tests, which is the chest X-ray. And this is going to give us a better picture where to, it's going to give us an idea where the abscess is happening, and also the size, the volume, and also it will give us a picture where the cavity is occurring. Okay, and this is going to be followed up with a chest CAT scan. So with this testing, this will give us much better detailed images of the lungs, much better than the X-ray. It will also give us the exact size, the shape, and also the position of the abscess, and to identify if there are multiple abscess in the lung fields. And the benefit, though, of having the chest CT scan, this is really going to differentiate between tumors, or it could be fungal infections. Now, moving forward with the next diagnostic test is the bronchoscopy. So what is this? Well, this is with the use of that fiber optic tube that is going to allow the diagnostician to visualize the inner structures of the lungs, the airways, and this is going to look for any tumors or any foreign bodies. And the diagnostician will also be able to get some tissue sample, maybe bronchial washings, and there can do some biopsies, so to analyze the tissues as well. Now, expect that there will be an order for sputum collection in order to identify the microorganism and to test what type of antibiotic that they're susceptible to. So don't forget about the sputum culture and sensitivity. Okay, that's very important. Now we're going to have to tackle the next diagnostic test, basically the management around this time. So how are we going to deal this? Well, antibiotic therapy is one of the mainstays. What we're going to expect here is to administer stronger antibiotics initially through the IV. This is usually the time when the patient is very sick. They're probably septic around this time, so we need to be aggressive in this treatment. And once the patient is improving in their status, then potentially the medical provider will switch the treatment into the oral form of antibiotics. Okay, and the therapy can last for several weeks in order to eradicate completely the microorganism. Okay, now another procedure that will be included in the treatment is the percutaneous drainage, and this is going to be done under interventional radiology. So another invasive type of procedure. You're going to have to prepare your patient, their consent, make sure that they are placed in, I believe they're going to be placed on NPO as well. And also, this will facilitate the drainage from the lungs if in case they are not really responding to the antibiotic therapy alone. So that percutaneous drainage is going to be needed in order to improve the patient's breathing, and this is going to be done under CAT scan, real-time CAT scan, or let's say an ultrasound. Let me just put US ultrasound and CAT scan in order to guide the needle during its insertion into the lungs and to prevent any complications from happening. Now, expect about the bronchoscopy is another diagnostic test in order to drain the abscess. They can also do the washings inside the lungs. However, though, the effect of the bronchoscopy in the lung abscess somewhat kind of it's varied. It's not really that consistent compared to with the use of the percutaneous drainage. Now, nutritional support is also important in our management here. We want to make sure that the patient is getting enough uh, nutrition in order to fight the infection and also to provide them with a high calorie, high protein in order to support the healing process and boost their immune system. Now, part of the care is to actually watch for the complication and expected that the patient might end up with a hemoptysis, right? Because of the involvement in the tiny structures in the lungs. They're going to end up with that. Hemoptysis. There's also the collection of pus, or known as the bronchopleural fistula. So here, the patient will end up with that abnormal passageway or network that can also cause pockets of pus. Okay. Now, there is also going to be lung entrapment and necrosis. This is another complication that is going to prevent the lungs from expanding properly when they are inhaling. So this is why it's referred to as the lung entrapment. So it's basically like an equivalent to cardiac tamponade. So when the patient is breathing in, it's restricting the inflation of the lungs. So you're going to expect much more of less oxygenation in this type of complication. Okay. Now we're going to talk about the lung abscess expansion as part of the complication. So if they're not really responding to the antibiotic therapy, then the infection will go into the nearby tissues as well in the lungs and will be affecting maybe the right and the left side of the lungs. Now, we're going to talk here about the nursing actions. And so part of that will be to assess the patient, make sure that we are examining the patient's mouth, especially with the dental hygiene. Why? Because if there is poor dental hygiene, this can increase their risk of infection. Okay. And same thing with the chest examination. Definitely don't forget to do the auscultation and the percussion. Make sure you're going to keep an eye out or ear out to listen for those adventitious sound, the crackles, the rhonchi, the diminished and absence of breath sounds. So once you're going to hear absent breath sounds, well, that's not a good sign. That simply means that your patient is now getting that atelectasis. Now, we're also going to have to check the patient's vital signs, the temperature, in order to determine the effectiveness of the treatment and to see if the patient may have an ongoing type of infection. Well, you got to track the temperature in order to see if a patient is responding to the antibiotic therapy. Now, part of the care is to assess the energy levels of the patient, their appetite, because if they're not really getting enough nutrition, or if they are just so exhausted, that simply means that our patient is really sick. And all the more that we need to be aggressive in delivering the care to the patient, not really aggressive physically, but we have to really keep an eye out, making sure that we are ahead one step before the patient can really worsen. Now we have to assess the patient for the hypoxia, check for restlessness, increasing confusion, cyanosis. These are not good signs. These are ominous signs that your patient probably will go into respiratory failure. I don't like these signs at all. Restlessness, cyanosis, confusion. No. This will call for a rapid response team, guys. Especially if the patient is going downhill fast before they code. Yeah, alert the rapid response team right away. Now, we're also going to have to perform postural drainage, and this is to facilitate the movement of those thick secretions. We're also going to have to encourage the patient to perform the coughing and deep breathing, and make sure that we're also encouraging oral fluid intake to thin the secretions. And we're also going to have to educate the patient and so many things, including the antibiotic therapy, that they need to be taking the antibiotic for quite some times. It will be extended ABX therapy. Extended ABX, antibiotic therapy. And why do we have to do a more extended antibiotic therapy? Well, this is one way of eradicating the patient's infection. And once they complete the antibiotic therapy, they need to show up for their follow-up appointment, make sure that we can get a follow-up sputum exam for culture and to check if the patient still has the microorganism. All right, if in case there's still an ongoing infection, then we need to keep an eye out, inform the medical provider, and possibly the medication therapy will be much more extended as well. Okay, we really want to make sure that the infection is going to be resolved, or else the abscess will not be cured. Okay, now another is to include the oral and periodontal care. This is very important, and the reason for that is to prevent recurrent infections. So like I have said earlier, when the patient expectorates sputum, the gunk, make sure that they rinse their mouth, they brush their teeth, use that mouthwash to ensure that they're getting rid of those bacteria. We don't want this bacteria to grow in their oral cavity. It's just nasty. Now, we're also going to have to make sure they follow up, show up for the appointment, especially when they need to have that chest x-ray in order to follow up for any improvement. In order for us to give an idea that maybe the abscess cavity is closing properly. Another education here, guys, is to make sure we are teaching them about aspiration precautions. So the goal here is to prevent those incidences wherein the patient can potentially choke on their food, or maybe choke on their saliva or their sputum. And this is happening more in the older population. Okay, they're really prone to developing those because of pre-existing swallowing difficulties. So you have to teach the patient, making sure that they adhere to the aspiration precaution. Now, we're also going to have to teach the patient regarding their overall health. Make sure that they have balanced nutrition, rest, and exercise. And just to recap about the lung abscess, it's quite challenging really to manage here, guys. It's going to require a much more comprehensive approach. We have to have a much more accurate diagnosis through collection of those samples, make sure that the patient will undergo those testing, make sure that we are delivering the antibiotic therapy, those treatments in order to get the patient towards the recovery. We need to be diligent in delivering the nursing care, and same thing with the patient education. You have to make sure that the patient understand in order to gain much more of compliance, especially when they get sent home. Yeah, this is a challenging part, guys. When we are sending them to their home setting, then there's the real challenge for them. They probably can come back to the hospital within a week's time because probably they're not following the education, or maybe they're just not able to do the self-care at home. And so you have to identify really the needs of this patient. Maybe they need to be sent to a nursing home, or could be needing a 24-hour caregiver at home, so to help them with their care. All right. Now, moving forward, we are going to talk about the last topic of the day, which is the empyema. And you're already seeing here a pocket of pus in the pleural space. Another gunky secretion staying in that pleural space. So what is the empyema? Well, this is another serious condition that is pertaining to the collection of that infected fluid. We're talking about the buildup of the infection inside the space, okay, the pleural space itself. And this is going to often form a thick wall, and it's because of the fibrin. Yeah, the disease process itself will allow them to form a fibrin, a thick wall. That would make the treatment very challenging as well. Now, let's talk about the etiology and the pathophysiology of the empyema. Well, this is something that can develop in about 20% of, or actually 32% of cases in the US per year. Okay, that's a lot. And this is going to be a complication when the patient has the pneumonia. Okay, so pneumonia is no joke, guys. It can lead to empyema if it's not treated well. And also the pleural effusion. Okay, so again, the pneumonia itself can complicate into a pleural effusion, and eventually the pleural effusion can lead into the empyema. And again, with the cases of about 32 or 20 to 32% of cases, actually 32, yeah, 32K. All right. Now let's move on into the high mortality and also morbidity of the disease process itself. So that is about 20 to 30%. That is a huge chunk of people having that morbidity and mortality rate. And this is going to be caused by that parapneumonic type of effusion, and about 70% of the cases can lead into empyema. And also for those patients that may had trauma to their chest, or could be after a surgical procedure to their chest or the thorax, this can also lead to about 30% of the cases. Okay. Now, for the empyema, this can also occur on its own, okay, in the absence of pneumonia. So this is what we call as primary empyema. So it can spontaneously develop without a prior infection. None of this, okay? So this can show up in just out of nowhere. And of course, overall here, the empyema can result to the common infection caused by the Streptococcus species, let's say the community acquired empyema. It can also be, it can occur after an infection, let's say the Staph aureus, or let's say the Pseudomonas. This is what we usually refer as the hospital acquired type of empyema. Okay, so guys, this is the difference. For the community acquired type of empyema, the microorganism that's causing it is the Streptococcus pneumoniae. And for the hospital acquired, we're gonna target on the Staphylococcus aureus and also the Pseudomonas aeruginosa. Those are the nosocomial types of microorganism. Now, if in case there is what we call as the Candida type of infection, Candida type of empyema, this is quite rare, but this is much more fatal compared to the others. Okay. And so we're going to really have to be attentive into assessing, make sure that we are gathering those manifestations and to see how bad or how severe they are experiencing with regards to the manifestation, so we can address those timely. Now we're going to talk about the different manifestations here. It's very important that we are recognizing the patients, how they're showing those symptoms that might mimic those of acute respiratory infections, or it could be pneumonia. And so one of those assessment findings will include the fever. And this is a very common, it's not isolated to empyema itself. And again, it's generic in most respiratory infections. There will be night sweats, and this is going to be bothersome, okay? And some care providers probably would just think about maybe tuberculosis, maybe, but we really need to rule out those type of infections as well. Chest pain is another thing. This can possibly occur on one side of the chest where the empyema is located. So chest pain that is localized. Okay, it's not diffuse type of pain. However, though, the quality of chest pain can be, it can range from being sharp, or it could be stabbing type of chest pain, or it could be a dull ache. All right. So here are the different types of pain that you might be assessing in this patient. It will be localized, it could be sharp, it could be stabbing, or it could be a dull, achy type of chest pain. Now, for the most part, they're going to be suffering from the continuous coughing. This is going to be productive, and in some cases, this was going to be blood tinged. Blood tinged, or could be rusty colored. Ooh, rusty colored, blood tinge. Now, the patient will have difficulty of breathing because of the infection that is progressing and because of the fluid buildup inside the lungs. Actually, the pleural space, to be specific, guys. So let me just try to draw here, especially if this is like the lung. Okay, let me try my best here. And then here's the pleura encasing the lungs. And there is that collection of pus in this area. And that's quite significant. With that collection of pus in the cavity or in the pleural space, this can really cause the limitation of the lung expansion when there is a huge amount of pus. So you will see the patient having difficulty breathing, their oxygen saturation will drop, and in severe cases, this can lead into the compression of the lungs and also compression of the heart, and also will compromise the return of blood flow to the heart as well. Just like in not pneumothorax, by the hemothorax rather. So it pretty much has that kind of effect into the lungs, the heart, and then also to the vena cava. So in some cases here, when it's very severe, it can compromise the blood return. So please don't forget this. I actually included this in our discussion about the hemothorax, the pneumothorax. So there will be decreased blood return. It can also compress the heart, compresses the heart and the lungs. So again, the function of both organs is increasingly, it's severely affected, guys. So think about the immediate complications that may arise. Now, the person will also have some loss of appetite because of the systemic infection that is occurring. As a general response to the illness, they're going to end up with some weight loss. And this is because of the decreased appetite and also the increasing metabolic demands during the infection. And the person will also have probably much distinct or less distinct symptoms. So what I'm talking about here is that the patient with an immunocompromise probably will not manifest a lot of these manifestations that I had mentioned. So probably they're not really going to manifest the fever because of the suppression of the immune system. And so this is really going to make your care so challenging. Because of that, the nature of the disease process is just going to be more challenging. And we definitely need to make sure that our patient will be treated aggressively, of course. But before we can do that, we need to identify the following diagnostic test. And it is known that the treatment of empyema is going to be challenging because of the very unspecific or non-specific nature of the clinical symptoms, because it's associated with so many other kind of problems in the lungs. And so the diagnostic test will not only involve the chest x-ray, but also will call for the other testing. Now, again, top of the list is the chest x-ray. I'm not gonna discuss in depth about this, but it will show probably some pleural effusion detection. However, the chest x-ray will really require about 75% of, or 75 mLs at least of pleural fluid in order to detect that one, okay? So this is really going to tell us that the chest x-ray itself is quite limited to diagnosing the problem. And also, if the patient has the pleural effusion, it will require this amount of fluid inside the pleural space, 175 mLs in the anterior view. So if the pleural fluid is lesser than that, then probably it's not going to be detected easily. However, though, we have the ultrasound, which is very helpful. And this is going to really identify the amount, the volume of the pleural effusion. And this is going to distinguish the lung tissue from the pleural fluid. And it is much more sensitive compared to the chest x-ray. Okay, so this is highly favored compared to the chest x-ray. Now, what you can probably see in the ultrasound reading is that there could be some homogeneous echogenicity, could be anechoic effusion with hyperechoic septation. And so, again, this will really detect the volume of the pleural effusion. Now, thoracentesis is another diagnostic test that will give the medical provider a better idea on how much fluid is inside the pleural space, right? And here we are going to drain that fluid, of course, and after that, it will be analyzed and to determine for the microorganism that's causing the infection, and also to identify the best antibiotic therapy to eradicate that infection. Now, moving forward here, what are we going to do to treat this patient? Well, on top of that will be the antibiotic therapy. Make sure that we are giving them the antibiotic that really would target the infecting microorganism. And so the approach for the community-acquired empyema, we're going to be administering the third or fourth generation cephalosporin, okay? And this is going to be given in combination with the metronidazole, or it could be the ampicillin with the beta-lactamase type of inhibitor, because our patient's infection probably would be kind of resistant to the other forms of antibiotics. And so we want to make sure that our patient is getting adequate coverage to fight off that infection. Now, for the hospital-acquired empyema, or could be the trauma-related empyema, what we're going to do here is to administer the antibiotic, including vancomycin, or it could be the cefepime, or including the metronidazole, or known as the peptazo, the piperacillin tazobactam. Okay, so this is a very common antibiotic to treat the hospital-acquired type of empyema. All right. Now, another treatment here is the thoracostomy. This is going to be helpful in decreasing the amount of fluid in the pleural space. And also the consideration will include the size of the tube itself, the catheter, because it can be uncomfortable if the medical provider will be inserting the bigger French. And so we want to make sure that the tube is in the smaller side, usually around 14 French. And it should be confirmed by the chest x-ray. And I'm talking about the placement of the thoracotomy tube. And with the care in the thoracostomy or the thoracotomy, we need to at least check for any kind of improvement within the 24-hour period after the insertion. Because if there is no improvement, what does that indicate? Well, it could be that the tube has been blocked by the thick secretions. So that's not a good thing. All right. And we want to make sure also to see for the placement, make sure that it is going to be confirmed by a follow-up chest x-ray and this is to confirm for the position. Because if there is low output of the drainage, then this is probably caused by the malposition of the tube. But in order for us to prevent the blockages, we need to obtain an order from the medical provider, maybe a need for us to do frequent flushing. And this is going to be done in a very rare condition, but we just have to prepare that we might need to flush the thoracostomy tube as ordered. Okay. And so this is really gonna require us to monitor the amount of the flush and the total output. But again, this is more complex step that we can do to this patient. Yeah, very complex. We don't usually do the flushing into the test tube unless it's really given by the doctor. Now, we're also going to be considering the removal when there is now, I'm talking about thoracostomy. So expect that the tube will be removed, especially when the drainage will be lesser than 350. Let me write that again. If the drainage is getting lower or the volume is getting minimal, let's say less than 350 mLs per day, then definitely this is probably one of the criteria rather, to remove the thoracostomy. But also remember that our patient will require the daily chest x-rays to find out the volume of the pleural fluid. Okay, so that's just not about the output, but also checking into the daily chest x-ray results. Now, apart from the care plan here would be to also include the injection of the intrapleural medications. So what are these medications? Well, I think I've mentioned this in my previous topics. So one of those medications are the fibrinolytics. Okay, so what are these fibrinolytics? So here are your urokinase. Remember about these medications in pulmonary embolism: urokinase, streptokinase. So these are special medications that will be administered by the provider in order to break down the fibrin. Okay, so this is the protein that is involved in the formation of the fibrous tissue. And this is going to be very problematic, especially. I'm not talking about the medication, but the formation of the fibers or the fibrin itself can make the drainage of the pleural fluid very difficult because it's really going to be thick. And so that's the reason why the fibrinolytics will be critical. In order to lyse, it will dissolve, it will break down the fibrin. And also, the goal for this medication is to improve drainage. Okay? Improve drainage of the infected pleural fluid. And again, when there is proper drainage of the empyema, then you're going to expect that there will be much more of improvement, right? The patient will be breathing much easier because it's the fluid that's the problem itself. And we're also going to expect some combination of other medication, like, let me erase that, the mucolytics. We call this as the Dornase alpha. So what is this Dornase alpha? Well, this is going to also allow the expectoration of the thick secretions, all right? And this is also going to break down the mucus, which will help thin, and it will also loosen the mucus and will assist the patient in coughing up the secretion as well, okay? But again, guys, this is going to be much more applicable to a patient with a cystic fibrosis. And cystic fibrosis can also complicate into the empyema. Okay, cystic fibrosis related empyema. Remember about the cystic fibrosis with that problem in the movement of the chloride from that channel. It's really going to make the secretions very thick. And so the Dornase alpha will help out in liquefying the secretions. Now, we're also going to talk about the surgical intervention if in case the other modalities will fail. And so this will involve the removal of a section of the lungs, or it could be the removal of the pus from the pleural cavity in order to allow expansion. Okay, so here are the different procedures. One is the video assisted thoracotomy, or known as the VATS. And so here we are going to expect less invasive type of procedure. There is lesser blood loss. Okay, lesser complication, lesser blood loss, less pain. There will be improvement of the respiratory outcomes, and the patient is expected to have shorter hospital stay and also lower 30-day mortality because of a much less invasive procedure. So don't forget about the VATS, the video assisted thoracotomy. And then we also have the open thoracotomy, which is much more invasive, but also it will be needed if in case the person will end up with uncontrolled bleeding, or if there is significant damage that cannot be fixed using the laparoscopic type of procedure. This is going to be indicated, especially if the patient has the inability to tolerate one lung ventilation. And so this is really going to be more helpful for the patient. But again, with this much more invasive type of procedure, we need to keep an eye out for this patient because of the post-operative complications. Now, another treatment that we can expect in this patient is the decortication. So what is this decortication? So this is basically the procedure that will remove the restriction, and also it can alleviate the symptoms of the patient. So what is this? This is going to remove the fibrous, thick tissue. So this is basically the pleural peel that will be removed. Pleural peel. So the procedure itself is known as what we call as pleural peel. So it will now remove the thick fibrous tissue that is actually formed outside the lungs, and it will now resolve that issue, because with this problem, if there is fibrosis, this is going to restrict the lung expansion. And so the pleural peel will really be advantageous for this patient. Now, what is the indication for having the decortication? Well, one of those is the chronic empyema. And also if they have responded, failure to respond to the other modalities. Failure to respond. Let me just erase this. This is way crowded now. If the patient is not really responding to the other modalities of treatment, then they're gonna benefit this decortication. Failure to respond to other treatments. Again, they are gonna need this procedure if in case they have chronic empyema because of that fibrous tissue that needs to be removed, and also if the patient has failure to respond to other treatment modalities, so they will get really the benefit of the pleural peel procedure. Now, moving forward with our nursing actions, this is where we really need to focus, guys. We want to make sure that our patient's respiratory function is supported. We have to manage their infection. We want to make sure that we are also ensuring effective drainage of the lungs. And of course, education is key in delivering the nursing care. Okay, so one is this respiratory support. Make sure that we are assessing the patient's respiratory rate, the breath sounds, the effort, also the oxygen saturation, and we got to make sure that we are also controlling the infection with the delivery of those different anti-infective therapy. We want to make sure that our treatment is timely in order to eradicate the infecting microorganism. And also we're going to have to practice aseptic technique in whatever procedures that we are performing for the patient. Either it's a regular IV access or just the care of the patient, maybe just a bath or assisting them to do the oral care. Everything needs to be aseptic technique in order to lessen the incidence of infection. The more that we're going to have to be careful, especially if they are having the chest tube, we want to make sure that we are preventing any avenues of potential infection. We need to avoid those. Also, we got to be careful in managing the drainage system, especially with the chest tube. We want to make sure that all the tubes are functioning properly. Make sure that we are looking for the tidling, the bubbling, so to check for the blockages as well, or maybe there's any air leak. So we want to make sure that we are maintaining those safety measures. So again, if you have not watched my video yet regarding the pneumohemothorax, I highly recommend that you review that content. Now, part of the care is also to maintain the patency of the drainage to make sure that we are allowing the re-expansion of the lungs. And the pain management is also very important, guys, especially if they had invasive procedures. Make sure that they're getting the adequate pain relief and to monitor for the effectiveness of the pain medication. And also, we're going to incorporate here breathing exercises with the use of the chest physiotherapy and with the use of those flutter device, incentive spirometry, the deep breathing techniques, and same thing with gradual mobilization. So this is quite challenging, especially for those patients that may have been bedridden for quite some time. So it will take a few more days to cause the patient to have some progress with their physical activity. And again, the involvement with the physical therapy staff is very crucial to prevent more complication. And we are also going to promote fluid and nutritional support for the patient. And this is to allow tissue healing, to maintain the hydration of the patient. We want to make sure that they're getting enough fluid intake to thin the secretions, and also to maintain good amounts of high caloric, high protein diet to make sure that they will be able to build their immune system as well. We're going to have to monitor the nutritional status, make sure that we are monitoring their weights in a daily or maybe weekly frequency to make sure that we are attaining our goals. And our education for this patient is very critical, guys. We want to make sure that we are teaching them about the disease process itself. How does it occur? And the causes, the treatment. We got to make sure that we are emphasizing the compliance to the antibiotic therapy in order to prevent resistance. Okay, that is the meat of our patient education. Now, part of the patient education is also to manage the chest tube care at home. Okay, that's another one. And also the follow-up care. Basically, the patient will end up with more testing, especially the sputum. How can I get the outline? I'll find out. How can I get you the outline? I'll have to speak with my boss. All right, sputum exam will be done in order to, probably we can get it to you with our YouTube channel. We can get you some notes. And so with the sputum exam, this is going to follow up if there is now total eradication of the microorganism. Make sure that This is done after they complete the antibiotic therapy, or else if they're not going to comply with the sputum exam, then we don't know if the organism is still there, right? And the chest x-ray will need to be taken again in order to check if there is still collection of the pus in the pleural space, or if it's no longer there, then that's good, right? On top of that, we're also going to support the patient's emotional side. We're going to have to give them assurance, reassurance, addressing their fears, their anxieties, and if possible, we need to refer them to counseling in order for them to cope with the stress of their illness and also the treatment, because this is really debilitating, guys. This will really restrict their lifestyle, because who wants to really do something, any kind of strenuous activity, exercise, if you get short of breath? And so this will really limit the patient's daily exercise. Even just simply going to the store to their do shopping or maybe playing golf could be so strenuous for them. And so, yeah, it's gonna affect their lifestyle in whole. Now, we want to make sure that we are implementing these interventions and also make sure that we are providing much more in-depth patient education. And again, that is very key. That is a key component. Make sure that our patient will be compliant to the therapy. And to recap everything here, our priority here will be on the nursing care. Make sure that, for example, the case that we discussed earlier about the bronchiectasis, the goal of our treatment is to keep airway clearance and also giving them the education on the pulmonary hygiene, and make sure that they are compliant with the therapy, especially with the antibiotic therapies. And with the lung abscess topic, our role here is focused more on the monitoring and the signs of any sepsis, worsening of their infection. We're going to administer the antibiotics. We're going to assist them with the drainage procedures, and also with the empyema. Our management here will involve close monitoring of their respiratory status, assisting them with the chest tube care, and make sure that we are providing support to provide the comfort and also the recovery. And it's very important that we are very proactive in involving the patient themselves. Make sure that they participate. They have to really allow themselves to learn the different treatments in order that they can be compliant at home. Okay. And so I hope that you were able to capture a whole lot of insights from this lecture. And I hope that you were able to recall those fundamental nursing care that you have learned in the past. So I'm just kind of like trying to dig those concepts so you will be able to retain and remember those important topics. And again, I highly recommend that you will be taking sets of NCLEX questions related to the topic in order for you to evaluate your learning today. And I hope that you enjoyed our discussion today. And I will be seeing you again the same time at 9 p.m. Eastern time. And we'll be talking about the pulmonary hypertension, which is pretty much related to the previous topic that we talked about, the cor pulmonale. And so we're going to dig into that discussion tomorrow, 9 p.m. Eastern Standard Time. And so that's it for today. Thank you, and you take care. Bye-bye.